Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Preliminary Results of a Phase 2 Trial of Proton Radiotherapy for Pediatric Rhabdomyosarcoma by Matthew M. Ladra et al. My name is Suzanne Walden, and I am an attending physician at the Memorial Sloan Kettering Cancer Center in New York City, USA. My oncologic specialty is pediatric radiation oncology. This important manuscript provides the first prospectively collected data supporting equivalent efficacy of proton therapy compared to photon therapy in the treatment of rhabdomyosarcoma. Here, Ladra et al. Report preliminary outcomes for 57 pediatric patients enrolled on a Phase 2 study using proton radiotherapy for local control of rhabdomyosarcoma. This study was designed to assess disease control as well as acute and late side effects. Patients with low or intermediate risk rhabdomyosarcoma received radiotherapy at one of two participating centers. Compared to the general population of patients with rhabdomyosarcoma, patients were young with a median age of only 3.5 years and a range of 7 months to 19.5 years. They were also more likely to have primary tumors in the head and neck, with 44 of the 57 having orbit, head and neck, or perimeningeal tumors. All patients received varied but standard chemotherapy regimens as well as radiotherapy doses. With a median survivor follow-up of 47 months, disease control and acute toxicity results are fairly mature. Local control, event-free, and overall survival for low-risk patients, primarily those with orbit primaries, were excellent and very comparable to the last Children's Oncology Group low-risk study, D9602. The outcomes for intermediate-risk patients appear somewhat inferior to those of the most recent Children's Oncology Group intermediate-risk study, D9803, with event-free and overall survival of 61% and 70% compared to 68% to 73% and 79%. However, the authors note that their results fall within the confidence intervals of the D9803 outcomes. Slightly poorer local control could be attributed to a higher prevalence of perimeningeal tumors. Dosimetric analyses showed that no patient suffered a marginal miss, which has been a theoretical concern with the sharp dose fall-off of proton beams. Indeed, all 10 local failures occurred within the high-dose treatment volume. In spite of the small size and tumor heterogeneity that are inherent to a trial for this rare disease, one may conclude that disease control outcomes are similar to published data for photon-treated patients. In terms of acute toxicity, it is difficult to quantify short-term advantages of proton therapy. The 17% rate of grade 3 toxicity is relatively low, but is difficult to put into context with the very limited published data for modern photon techniques, such as IMRT, where rates as low as 0 have been reported. Reporting of acute toxicity such as skin erythema and mucositis tends to be variable and subjective, in spite of published common criteria. Acute toxicity during radiotherapy for rhabdomyosarcoma is entirely dependent upon the site of treatment as well as field size. A patient receiving radiotherapy to cervical lymph nodes will have much worse mucositis than a patient receiving radiation to a sinus tumor alone. Acute toxicity is also dependent upon the type of concurrent chemotherapy, which has varied substantially on recent trials. With so many confounding variables, it is difficult to compare acute toxicity based on radiation modality. The real promise for improvement in outcomes with proton therapy is the expected reduction of late effects, such as secondary cancers, which typically occur more than a decade after treatment. At the current time, we cannot draw any conclusions about the impact of proton versus photon late effects based on these data. With years of continued long-term follow-up, meaningful conclusions may be drawn from this trial. In the meantime, we should soon have the ability to do analyses of patients treated on the same arm of the same cooperative group study with protons versus photons. These additional studies could be helpful in quantifying differences in acute and eventually late toxicity between the two radiation modalities. For now, we are left only with the hypothesis that a lower integral dose will be associated with fewer long-term complications. The potential for long-term benefit with protons is variable and depends upon patient age, tumor site, field size, and numerous anatomical considerations. In some patients with rhabdomyosarcoma, there may be little to no potential benefit with protons. Thus, patient selection remains important. The young patient age and large number of head and neck tumor sites in this study indicate that these considerations have been reflected in referral patterns. If one believes, as I do, that this study shows equivalent efficacy of proton therapy, then the only remaining impediment to the use of protons for rhabdomyosarcoma are the rather significant obstacles of cost and access. Proton therapy is more expensive than photon treatment, but most insurance companies have been willing to cover the higher cost because of the assumed long-term benefit to young patients. It is worth noting that white children are overrepresented in this trial at a rate of 88%. In the most recently published Children's Oncology Group trial, D9803, 67% of patients were white. This raises concern about equal access to care for children from lower socioeconomic backgrounds. The logistics and expense associated with relocation to a proton center for treatment are overwhelming for most families. Even when insurance will cover the cost of treatment, proton therapy remains beyond the reach of many children. In summary, this article provides evidence that proton therapy is equivalent to photon therapy for achieving disease control in patients with rhabdomyosarcoma. This is a significant addition to the growing body of literature supporting equivalent efficacy for proton therapy in pediatric tumors. A potential reduction in acute and, more importantly, late radiation effects must be studied as longer follow-up becomes available. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.